So if you're just finishing up the quiz, just have a go at the last few questions. Okay, otherwise we'll kickstart the session. So today we have Thomas Hickman Casey teaching us. He's a clinical fellow who's based at the Royal Sussex County Hospital / Eastbourne. He chooses his time of depending on whichever pays higher locum rates. So between those two hospitals, he spends most of his time. He's from a lineage of ophthalmologists himself, so he knows what he's talking about. He loves ophthalmology and he sees a future career in it just so he can make daddy happy or make his whole family happy. But he's very knowledgeable in the field. He knows what he's talking about. So I'm very excited to introduce Tom Hickman Casey today. He'll be talking about the infectious diseases of the eye. Okay, so over to you, Tom.
Thank you, Yaron. So I'm going to give a talk on the infectious diseases. I think this will be a little bit sort of hopefully a bit easier, a bit more well known to you guys from what you've studied at medical school and your clinical placements, and it might be a little bit quicker than the previous sessions, but I think hopefully it'll be a good revision and quite high yield for the exam. So without further ado, we'll just crack on and do some cases, hopefully he says. So the first case, so 20-year-old female presents with this is a painful erythematous swelling of her eyelid, which is this red nodule, which is tender to touch at the level of the eyelashes, and it's got some pus. So systemically very well, normal visual acuity. Anyone know the diagnosis? So this is, Hordolium, so a sty. So you split these into two types. You have your external and internal. So your external is your sty, which this is infection of glands of the lash follicle. So this is your glands of Moll, which is a sweat gland, and your glands of Zeiss, which is sebaceous gland. And the internal Hordoliums, these are more painful, and this is sort of an infection of the meibomian gland, which is within the tarsal plate. So you often see this swelling of the eyelid, and they say that the pus points towards you. So this is commonly a staphylococcal infection, and it's common with dry eyes and blepharitis. So treatment is sort of conservative. You hot compress, your analgesia, but if it's particularly bad and it's associated with conjunctivitis, that's when you'd give some topical antibiotics. Okay. So the next, these are sort of very simple things to start with. The next one is blepharitis. So you all know this is infection of your lid margins. It's commonly bilateral. And you have this sort of gritty discomfort in your eye. And again, we split this into two parts, anterior or posterior. Someone in the chat. Oh, no, that's Yara. Yeah, so anterior, posterior. So the anterior, this is at the base of the eyelashes, and it's just inflammation of the skin, whereas the posterior is the meibomian gland, so it's dysfunction. And the posterior blepharitis is associated with rosacea. So that might be a sort of clinical clue in the history. But again, it's sort of hot compress, lid hygiene, and again, antibiotics, topical antibiotics. If it's a severe infection, and we tend to give tetracyclines for this. Can we assume we have a position that we've had no teaching on this? Yes, of course, yeah. So, this is common infection, and the complication of this is conjunctivitis. So we'll come on to that in a bit later. But yeah, this is sort of very common thing for GPs, and we treat mostly conservatively, but we can give antibiotics if we need to. And a risk factor, yeah, as I say, is rosacea and also contact lens wearers. In terms of the anterior blepharitis, we can again split that into two. So you have your Staphylococcus dermatitis. So that's linked with atopic dermatitis, and that's where you get hard scales on the lashes. And then we also have seborrheic dermatitis, which that's soft scales, but that's sort of bit too much detail. You probably don't even be difficult to sort of ask in a question on the exam. But I think that with the exam being online this year, they might have more photos than they previously had in the past. So just, I think it's a good idea for all of these. I've tried to include some photos on all the slides. So I think it's good just to, you know, when I suggest mention a condition, just have a look at all the Google images of them, just so you get an appreciation of how these things actually look, rather than just the descriptions as well, because they might have some more photos if they can do it online. So moving on to the next sort of cause of infection is the lacrimal system. So got a second case here. So 78-year-old female, painful lump sort of towards her nose and the lower eyelid. She's coming in unilateral red eye and discharge. This is painful and it's inflamed over to the punctum, but she's systemically very well and it's not affecting her vision at all. So does anyone just want to write in the chat what they think, if they know what this might be at all? Let me see the chat. Not quite. What kind? So no. So this is canaliculitis. So if you remember, can you guys see my the arrow of my cursor? Just, can you see the cursor? Yeah. Okay. Good. So yeah. So we have, if you remember the lacrimal system from the anatomy lecture, we have our punctum here, and we got the canaliculi, which sort of, this is, so you've got two of them, one on the upper lid and one on the lower lid, and the canaliculi drain into, and then you've got your lacrimal duct, which runs down the side of your nose here, and then your lacrimal sac is at the top here. So canaliculitis is an infection of the canaliculi. So this is just the duct below the punctum, which drains the tears. So you get a unilateral presentation of this associated with a watery eye. So because you're not draining your tears, so you're getting sort of, you're not being able to flush them all through. So you're getting watery eyes, a swollen lump, and the infection can cause some mucoid discharge. So if you put pressure on the swelling, you can extract some of the discharge, and it's often associated with sort of granules out the punctum. I put the most the pathogen, so I think it's probably worth knowing what organisms are most likely to cause them. But the risk factors would be sort of anything that's causing obstruction. So if a patient has particularly dry eyes, they might put in a punctal plug, which is just as what it sounds. It's to stop the flow of tears from your eye. But one of the complications of this is that it can get infected and cause this canaliculitis. So because it's quite superficial, we can give topical antibiotics for this, but also it's the same as the other lid problems. We can give sort of warm compress just to soothe it and help with symptom control. If you're having sort of recurrent infections here, you can do canaliculotomy, which is a surgical intervention to open this all up. What type of antibiotics? I think it's just broad spectrum. I'm not quite sure exactly. It depends what you think is causing this. I'm not exactly sure what would be the most appropriate, I'm afraid. So, more chat. Okay, so, oops. So this is the other differentials that you guys were mentioning earlier. So this is dacrocystitis. So this is just a little bit lower down in your lacrimal system. So this is also caused by an obstruction, and this is an infection of the lacrimal sac. Symptoms, you having this erythema and this swelling over the lacrimal sac, epithelial and excessive tearing. So this is very common in sort of people over 40. You can, so young babies sort of age of 1, not all of the ducts or the valves in the lacrimal system have developed properly yet. So you can get sort of what appears to be obstruction then, but that normally self-resolves and they're fully developed by the age of 2. So in children particularly, it's less of a pathological cause of this, but in older people it can be more common. It's obviously unilateral, and if it's recurrent conjunctivitis because you're not sort of flushing through all the tears, that would be an indication for surgical management. But because this is sort of a deeper infection, we have to give oral antibiotics for this. The type of surgical management is so epithelial. That's just sort of inflamed or excessive tearing. It's just more sort of an angry eye and too much tearing in there. So it's So the surgical intervention is DCIs. That's where they're creating a separate route for the tears to flow. So they manage to make an alternative pathway for the tears to drain. Okay. So, right, the next part of this case is about the orbit of the eye. So I've got another case presentation. So a young boy, recurrent respiratory tract infections, has a unilateral red eye, or red swelling around his eye, double vision, he's lethargic, and he has pain when he's moving his eye. And he's also got a temperature, quite a high grade fever, and proptosis. So that's where your eye is sort of pushed forward. So does anyone know the diagnosis at all? Yeah. So, and what imaging would you do for this? Yeah, CT. So here's a CT scan of a head. So what you can see, this is the proptosis. So you can see if you compare to the other side, the eye here is sort of pushed further forward, and we've got through the ethmoid sinus, we've got an orbital abscess, and this is putting pressure on the optic nerve and the medial rectus. So because of that, so when you're infecting on the optic nerve, this is of course affects the vision, and the medial rectus, so you'll have difficulty in adducting. Okay, so and this is the investigation that we do when we're unsure of the diagnosis. So orbital cellulitis, so it's an infection affecting the fatter muscles, so it's posterior to the orbital septum. So that's how we differentiate between orbital cellulitis and preorbital or periorbital cellulitis. So anything behind the orbital septum, that's more serious, and that's orbital cellulitis. So it's obviously an acute onset, painful, limited eye movement, high-grade fever, which can affect vision, and it's an emergency. So patients who have this will be admitted for IV antibiotics, and so the risk factors are sort of a previous upper respiratory tract infection, and the most common spread is from the ethmoidal sinuses. Patients who haven't had their Hib vaccine, so you might have, the question might be from a patient who's come from an another country which it's not part of their vaccination schedule, that might be a clue in the question, but it's normally sort of young children who suffer from this the most. So this is dual managed by ENT as well, so they refer to them and they would be they can drain the sinuses or the orbital if needed. But yeah, the CT will give you the clear diagnosis. One of the sort of severe complications of this is cavernous sinus thrombosis. I mean, there's lots of complications, but this is one of the most serious ones. So it presents sort of similar to that of orbital cellulitis. And one of the first is sort of compression on the 6th cranial nerve. So this is the first sign, and because this lies by the cavernous sinus, so you'll get a lateral gaze palsy. And the investigation for this is an MRA. So this is a angiogram MRI. So you'll be able to visualize the cavernous sinus thrombosis there. So we treat this with IV antibiotics if it's caused by an infection, and you can treat it with sort of low molecular weight heparin or surgical intervention. Okay. So in the previous picture, the alternative diagnosis was preseptal or periorbital cellulitis. So this is very similar, but it's much less severe. So similar symptoms about sort of a painful swollen lid, but it's sort of a diagnosis of exclusion. So you wouldn't have any, you wouldn't necessarily have a high grade fever, no change in vision, normal eye movements. But there's quite a bit of sort of symptomatic overlap, and the CT scan is what you would do if you're unsure of diagnosis. And in particular in children, you'd have a very low threshold for doing a CT, because obviously you don't want to miss if it is an orbital cellulitis. But the preseptal ones, it's more superficial and can commonly be caused by things like an insect bite or lid trauma. But the important thing is it can progress into orbital cellulitis. So you still want to treat it with antibiotics, but this wouldn't need to be admitted into hospital for. Okay. So the next diagnosis, this is very rare, so I think that this is probably very unlikely to come up, but I think it's just to be aware that there are other things that can, infections that can affect the orbit. So this is a fungal infection, which has got a very, very high mortality rate. So if you get this, it's really bad news. Very uncommon in the UK, but it would be sort of immunocompromised patients, and it's also linked with diabetic ketoacidosis as well. So we try to treat with IV antifungals and surgical debridement, but it's bad news if you get this, unfortunately. Okay. So moving on to the cornea. So another case for you. So 49-year-old who's a contact lens wearer, is coming with unilateral sudden onset eye pain, also describing a gritty sensation associated with a photophobia, discharge, and decreased vision. So on examination, this is what you see. So conjunctival injection with white infiltrates, and it can be a hypopia. I don't think you can see it really on this one. So does anyone know the diagnosis? Yeah, perfect. So I'll go through all the different types of keratitis here. So, and they all present quite similarly to that case, which is sort of a sudden onset pain, redness, decreased visual acuity, and this sort of sensation of a gritty or foreign body in the eye. So and with all of these, because it's sort of the anterior is the surface of the eye, it's more common in contact lens wearers. And the pathogen can change between most likely if you're a contact lens wearer or not. But the way to identify is we do corneal scraping for the microbiology. I must admit, I don't know a huge amount about all the stainings, how it works, but it's just something to revise for the exam. So I put on for these keratitis which stainings they use, and I think it's easy to write a question on it. So why is the pain sudden onset? So it's sort of because it's affected the continuity of the cornea. So the cornea could be quite painful if the structure of it's lost its integrity. So that's why it's painful, and then that becomes infected. And yeah, so it can cause, the complications would be sort of a corneal scar or your worst corneal perforation. So if we're suspecting this, it's sight threatening, so you need to treat with topical antibiotics, but these are quite intense. So you'd be telling the patient that they'd need it sort of every hour for 48 hours. You'd be treating patients for this, so you just tell them, this is sight threatening, and you're going to be having sort of 2 days of quite intense eye drops, but the risks are high. So intensive topical antibiotics. So the next type of keratitis is fungal keratitis. So again, as I said, similar presentation, and there are two different organs that I think is probably worth being aware of for the exam. So it depends. So would you admit the patient for hourly antibiotics, or you discharge them? So it depends on how competent the patient is. So if it's a sort of an elderly patient who you wouldn't be able to, or doesn't have anyone at home to be administrating this, then you would need to admit them to give them the antibiotics. So it just depends on their social situation. If they've got a partner who's able to do this, and they're able to sort of set alarms to be able to remember to administer them, because obviously they'd need to be waking up in the middle of the night. But if this is sort of an elderly patient who's a bit confused, or doesn't have anyone to help them, you might be able to admit them depending on what hospital, what you're at. But yeah, it's sight threatening, so you'd need to be able to give them to make sure that the compliance is good with the antibiotics. So this fungal keratitis. So the candida, this is common in immunocompromised patients. So you have this yellow-white infiltrate, and the classic sign is what they would describe as a mushroom or a collar stud morphology. So as I said, you might be expected to identify some of these in the exam, but if it's not, that will be the description that they give. And the other one is filamentous fungi. So this is common in, they might say, sort of farmers or agricultural workers, and it's often sort of like a tree branch or something like that, an injury to the eye, and that gives a branch-like infiltrate pattern. Okay. Maybe on to the next one. So another form of keratitis, and this is caused by acanthamoeba. And the key thing to differentiate here is that the pain is out of proportion to the clinical signs. So they're coming in excruciating pain, but you might not be able to see a huge amount on examination. But again, you'd want to investigate with corneal scraping, and this is associated with poor lens hygiene. So again, it might be sort of contact lens wear as swimmers in lakes, or showering with your contact lenses in, and things like that, which would give this the history away. And this presents with this ring-shaped stromal infiltrates. So in the photo, I think you can see it's quite clear here. So that's the next one. And then this is your classic herpes simplex keratitis. So the primary infection doesn't always cause this. That's normally sort of gives a blepharotic picture, but the virus remains latent in the trigeminal ganglion, and it can affect sort of all the layers of the cornea. So you remember back to Yari's lecture, 5 layers of the cornea. This can affect different layers of them. So the most outer layer is the epithelial layer, and this one causes a decreased corneal sensation. So as with the previous ones, it can be quite painful. This one is typically less painful, and that can sort of make you start thinking more about it might be a herpes keratitis, but you still have the same sort of foreign body sensation, but you get your typical dendritic ulcer, dendritic ulcer under the fluorescein staining. So I put here that you have your star-shaped or your terminal bottom. So if you look at the dendrites, it doesn't come towards a point. It's more sort of it's a bit sort of rounded at the ends of these. So that's the classic sign. And again, yeah, you swab. The important thing here is do not treat with steroids. This can make things a lot worse. So, but with epithelial herpes, you'd treat with topical acyclovir. But then, as I said, it can affect the different layers of the cornea. This is sort of the inner layer, innermost layer is the endothelial keratitis or the disciform keratitis, and it's painless, and you get this Wesley ring. So you can see that there, and that's just infiltrates. So but because this is at the inner layer of the cornea, you typically treat this herpes with oral acyclovir. Okay. So here we have herpes zoster. So you get this classic dermatomal rash over the ophthalmic division of the trigeminal nerve. So again, you have the latent virus in the trigeminal ganglion, and when it reactivates, you can get this dermatonal pattern of the rash. It's typically a vesicular and papillar rash, and it can be defined as Hutchinson's sign. So Hutchinson's sign is this distribution, and if the rash affects sort of the tip of the nose, that means it's affecting the nasociliary nerve, which also supplies the cornea. So if the rash affects the tip of the nose, the probability of ocular involvement, your suspicion is higher. And the fluorescein here is typically not, so whereas you had your classic dendritic ulcer in the past, for your others herpes viruses, the herpes zoster, typically it doesn't sort of absorb doesn't stain well with the fluorescein. And we'd treat here oral acyclovir and then sort of analgesia for your neuropathic pain. But again, it's decreased corneal sensation. I've included interstitial keratitis. So this not always caused by an infection here, but the two infections that you should be able to that can cause this, which are syphilis and Lyme disease. So congenital syphilis typically presents bilaterally, whereas acquired is normally unilateral. So this is in the center layer of the cornea. And yeah, we'd treat syphilis with benpen and topical steroids. Okay, but yeah, this is not necessarily relevant to infected because lots of other things can cause this. Okay. So moving to another part of the eye here, so we have another case. So this has been very, very common, a young boy presenting with a sticky eyelid and plurulent discharge, and he can't stop touching his eyes. They're very uncomfortable for him. And when you have a look in them, they're red and significant amount of discharge. So any diagnosis? Yeah. So this is bacterial conjunctivitis. So as before, plurulent discharge, the eyes can be stuck together in the morning, grittiness, uncomfortable, not normally something that we worry too much about because it's normally self-limiting. But if it's severe, we can treat with antibiotics. We'd give, so it's normally chloramphenicol, but in pregnant women, I think they worry about aplastic anemia, so we give fusidic acid instead. So that was one of the questions in the pre. It's quite a difficult one. It's not always adhered to, but in theory, that's what we should be giving in pregnant women. So viral conjunctivitis, again, similar sort of presentation, but this is with a watery discharge. And the key in the history here is they're going to have lymphadenopathy as well. And this is incredibly infectious. So it's very common for sort of household members who are sort of sharing towels and things like that, or to catch this as well. You not often see outbreaks of this, but unfortunately this can last months and months, could go on and on. It should be self-resolving. We can treat with steroids, but in some cases, unfortunately, when you stop the steroids, the infection, the symptoms come back, and typically, it will starts unilaterally, but will progress to bilaterally. But it's the lymphadenopathy, which is that's your key in the history to be able to differentiate it from bacterial, and the fact that the discharge is watery. Okay. So again, this isn't really ineffective, but I thought, seeing as I'm covering the other parts of conjunctivitis, I'll include allergic conjunctivitis. There's 4 types of this. I think that's probably a bit too much detail. I think it's important to know that it's the seasonal allergic conjunctivitis is IgE mediated, is type 1 hypersensitivity. I think that's probably all you really need to know. So no, you wouldn't. Sorry, so someone's asking if we treat viral conjunctivitis with antivirals. No, you wouldn't. No, wouldn't really do that. I don't think it's severe enough to really to warrant treating with antivirals. But yeah, so allergic conjunctivitis, very, very itchy, normally self-resolving, and it's about minimizing the exposure, but you can treat with some antihistamines and artificial tears for comfort. Okay. And so I think this is my final conjunctivitis. So this is chlamydia conjunctivitis. So unilateral, you also get your lymphadenopathy here, but you get sort of a stringy discharge and the white follicles. So I think you can appreciate here that you can just see some follicles, and you wouldn't necessarily see those with the other types of conjunctivitis. And this is sort of associated with your writers or your reactive arthritis. So this is the way you say you can't see, pee, or climb a tree with the triad of symptoms. Yeah. So we treat this a stat dose of azithromycin or 14 days of doxycycline once a day. And you can refer to an STD clinic as well. So I got another case here. So 28-year-old chap from Ethiopia, chronic red eye, discomfort, photophobia, and discharge. And you can see this chap has also got follicular conjunctivitis, and it's normally on the superior tarsal plate. Does anyone know any diagnosis for this? Yeah. So this is the most common cause of infectious blindness worldwide. I think this sort of suffer from this. So it's very sort of endemic in Africa and South America. So it's type 4 hypersensitivity, and transmitted by the basilar fly. So and it's split into two main stages. So who have a five stages, but it's sort of largely split into the inflammatory phase, which is the infection phase, and then the scarring after that. So so you see the infections cause these follicles, which are normally in the upper tarsal conjunctiva, which causes thickening and irritation, and that can lead to scarring. So the tricases, this is where your eyelashes are sort of ingrowing, and they can sort of irritate the cornea, and that leads to opacity and inflammation in the cornea. So in terms of management for this, it's sort of split. For antibiotics, we give that for the infectious part, but then if this develops and it does cause these eyelash ingrowths, then you can do surgery for that. But obviously the main thing here is prevention is better than cure, and it's all about sort of hygiene. And I think that's a big sort of trying to tackle that. Obviously with the leading cause of infective blindness. So the next case here is an elderly lady who's had cataract surgery 48 hours ago. She comes into your eye cavity with a very painful eye, blurred vision, floaters, and on examination you can see this hypopion and a corneal haze. Does anyone know differentials for this? Yeah, so endophthalmitis. So this is one of the worst nightmares of an ophthalmologist. So this is infection of the vitreous and the aqueous humor. So it's commonly a post-op complication, but there are other causes. But I think in terms of exams, this would be the main giveaway in the stem of the question. So it presents sort of a red, acutely very painful eye, and in severe cases you can see this hypopion here. So in terms of investigation, you'd want to do a vitreous tap, so that's where you take a sample of the vitreous, but you'd also treat with antibiotics at the same time. So you'd give intravitreal antibiotics. So that's the mainstay of treatment. I think you can do a vitrectomy if it's very, very severe. But yeah, this is sort of a very, very serious complication of cataract surgery, which is generally quite safe. And we can give sort of pre-op iodine, that's the prevention, but it's normally caused, if it's the first kind of couple of weeks after, first sort of week or so after the operation. It's normally your flora from around your periorbital flora, which is the infective organism before that. Okay. So a few miscellaneous cases here. Most of them are linked with posterior uveitis, but typically the next few cases can cause lots of different types of conditions affecting all different parts of the eye. So the first one here is TB uveitis. So the picture I've got here, this is your mutton fat keratitis precipitans. So this is the anterior uveitis. So I think the posterior uveitis is the most serious and most worrying feature of TB, but I think this is common mutton fat appearance that's with anterior uveitis, but as you can see, it can cause a whole host of different pathologies, and it's linked with your systemic features of TB, which is your night sweats, fever, hemoptysis, weight loss. And then this is the classic staining, the Ziehl-Neelsen stain. So another very sort of problematic common cause of infectious blindness, again, not often seen in the UK, but this is your African river blindness, so which also can cause a sort of maculopapular rush. So you get decreased visual acuity, sclerosing keratitis, you get optic neuritis with this as well. And the treatment is ivermectin, which they're also thinking this can be a treatment for COVID as well as, so it's in promising potential treatment. But yeah, it's very, very common. It's the second most common cause. So another case here. So 25-year-old living at home with a new pet kitten. Suddenly starts to feel generally very unwell, lymphadenopathy, fever, lethargy. She has a painless loss of vision, central vision. And this is what you see on direct fundoscopy. So this is described as a macular star pattern. So does anyone know any differentials for this? Yeah, that's the cause of it. So this is, yeah, neuroretinitis, cat scratch disease. So this is presents, you can have systemic features with this, the Bartonella henselae, and the common fundal exam is this macular star sign. So there are other causes of neuroretinitis, but this is the most of this is the textbook exam question. So it's inflammation of the optic nerve and the neural retina, and that causes edema and all the way from the nerve head to the macula. So you get your central decrease in visual acuity. So the management depends on the cause of this, but often needs antibiotics and steroids for this. So another form of retinitis, so CMV retinitis, so this is in AIDS patients, and it's an opportunistic infection when the CD4 count is less than 50. So retinal infection, and you worry about that it can lead to necrosis of the retina and retinal detachment. Importantly, this can be asymptomatic, as quite frequently is asymptomatic, but it also can cause visual loss, floaters, flashing lights as well. And And this is the described as the pizza pie or cottage cheese with ketchup. I'm not sure about that myself, but this is apparently what the description looks like. But this is just the hemorrhages in the retina. So it's clinical diagnosis, but you can do an aqueous or vitreous tap diagnosis, but we treat with sort of IV antivirals. So next presentation is toxoplasmosis. So again, quite rare in the UK, but it does occur. When I was a med student, there was a patient who they think that the most likely cause of his toxoplasmosis was from he had steak tartare at the Shard. Yeah, don't go ordering that. I'm sure the rest of the menu is very nice, but don't go ordering that. But essentially, it's Toxoplasma gondii, which is the cats are the vector to humans, and it causes this headlight in the fog presentation on fundoscopy. So you can appreciate that there, and it often accompanied by a scar next to it. And this is can develop into anterior uveitis, and we typically diagnose this with PCR if it's not sort of clear on from the history and the examination, and we treat with triple therapy. Okay, so I hope that was a good refresher and gave you sort of some tips for the exam. I think that it's sort of some of the treatments and the investigations, you just have to sort of sit down and learn them. But I think it's got a quite easy marks if you can put the time in, because it's not a huge amount of theory to learn. It's just sort of pattern recognition for the questions. So I think you can pick up some marks, and I hope this presentation can act as a revision guide for that.